This is EM Cases EM Quick Hits podcast. Quick, let's get on with it. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. All right, we've got some pediatrics for you now, and this is part of our EM Quick Hit series on the International Conference of Emergency Medicine, which is in Montreal this May. It's my pleasure to introduce or reintroduce, it's been I think 13 years since we've had Dr. Steven Friedman on EM Cases. He's a professor in the Department of Pediatrics and Emergency Medicine at the Cummings School of Medicine at the University of Calgary. He's been on EM Cases before, as I just mentioned, because he's the researcher who introduced the EM world to the wonders of ondansetron for kids who come in vomiting. That is pretty huge. I can hardly imagine treating kids in the emergency department without ondansetron. So I just want to say a special thank you.
A lucky endeavor at the right time, right? So it's often right place, right time, right idea, I guess. But I'm delighted that that's really been taken up into our general practice and really disseminated widely as far as use. And now the goal is to really optimize usage of that.
So Dr. Friedman is, I would say, this sort of the preeminent researcher and expert on pediatric gastroenteritis. And it was, I think, way back in episode 19 that we talked about all things pediatric gastroenteritis. And while we discussed plenty about kids with diarrhea, we didn't talk much about bloody diarrhea. And when I say bloody diarrhea in kids, the first thing we should all probably be thinking about is, you probably guessed it, Shiga toxin producing E. coli, or what we'll call from here on in S-TEC. So let's get into what we need to know about S-TEC in the ED. Let's just start with a general approach. Kid comes in with bloody diarrhea into the emergency department. What's going to be your general approach?
Yeah, obviously there are lots of factors that will really affect what you think about, obviously starting with age and other general systemic history and physical examination features. But I think in general, let's talk about the child who is not too unwell, who's had a brief interval of 1 to 3, 4, 5 days of bloody diarrhea. And once again, when we're talking here, we're differentiating from fissures and chronic bloody diarrhea like inflammatory bowel disease type presentations, et cetera. But in the acute bloody diarrhea, what we really want to think about is number 1, stability, number 2, hydration status, and really number 3, etiology. Most of these children are not having massive GI bleeds. So we're also kind of talking about hemodynamically stable children. And then once we start thinking of that, it's kind of what is the etiology? And infectious etiology should come to front of mind. And really kind of the most important thing that we can do for children with bloody diarrhea is obtain a stool specimen. So that is really going to be your frontline diagnostic tool and what's going to guide what's going to happen over the next several days. So the good news is that parasites rarely cause acute bloody diarrhea in children. So we don't need to test for parasites, actually, although it's commonly done. But what we do need to test for is bacteria. And it's important to note we also generally still talk about sending stool for culture and sensitivity. The reality is that most institutions across North America no longer perform culture as a frontline test. They're using PCR. So you're actually sending it for a nucleic acid molecular-based test, much along the lines of what we've gotten used to with COVID, et cetera. So it's tested for PCR, and it depends on your platform, but it varies. But most institutions are testing for Salmonella, Shigella, Campylobacter, and yes, S-TEC. And S-TEC is positive in approximately 10% of kids with acute bloody diarrhea. And it varies, though, based on your geography and your location. So this became a real interest of mine when I moved to Alberta because we actually have the highest prevalence of S-TEC in North America. And I started to see many more cases than I was used to, which is why I started to think about this more and look into it and understand it and figure out how can we optimize care of these children. So that is the number one thing to think about. The number two thing to think about is if the child is hemodynamically stable and generally well, you don't actually need to do blood work on all of these children. So whereas in adults, obviously bloody, diarrhea, GI bleeds can be a major catastrophic event, most children with blood in their stool do not have major findings in the blood work. They're not significantly anemic, et cetera. It's usually a small amount of blood. So blood work isn't necessarily required, but if you think S-TEC is high on the differential, then having baseline blood work can be very helpful for what happens later on if you do in fact find they have S-TEC, or even finding early signs of microangiopathy, which is the main complication that we see from S-TEC. And we'll talk a little bit more later, I guess, Anton, about the hemolytic uremic syndrome, which is kind of the consequences of that microangiopathic hemolytic cascade.
Let's just pause right there because there's a key decision point there, whether or not to do blood work. So how do you decide to do blood work in these kids that present with bloody diarrhea?
Yeah, so if they're unwell appearing, that's a different story. So hemodynamic instability, generally systemically toxic, I'm worried about sepsis, then they're getting blood work done. If they're significantly dehydrated, they're going to have blood work done. But if the child comes in, because parents often will come in after one or two small amounts of blood in the stool, and you look at it and you're like, okay, maybe there's a little bit of blood, but the child is up and running around the room, I don't generally think they need to do blood work. Children where I am highly suspicious of S-TEC, I will do blood work for them. These children typically have severe crampy abdominal pain. They're also having often 15 to 20, 25 episodes of small, frequent, mucousy, bloody stools. Or after the first couple, they're very small. They're not large volume. And they're having large amounts of abdominal pain, maybe a low-grade fever. The other group where I do blood work, where it's not usually S-TEC, are travelers. So travelers who come back with bloody diarrhea, especially if they're febrile, our standard of care would be to be doing blood work, not necessarily only because of the diarrhea, but we're looking for other things, such as, malaria or arboviral infections, et cetera. So those would be some of the main drivers for me. But I do increasingly encourage people to do blood work if you are highly suspicious of S-TEC based on the clinical history presentation. And then the other category would be a close contact with a known case, because we do know there's a very high household transmission rate of approximately 10% of S-TEC infection. So one sibling will give it to another sibling.
Okay, so just to review there, blood work is indicated for kids presenting with bloody diarrhea who are relatively stable. So this isn't the unstable kids. So acute, stable bloody diarrhea. If they have severe crampy abdominal pain, if they have like 20, 25 stools a day, so frequent diarrhea, if they have a fever, if they've been traveling, if they have close contacts with someone with known S-TEC, or in the unfortunate case of 2023, if there's an outbreak.
Yeah, and I'll add on obviously any signs that would make you suspicious for evidence of microangiopathy. I will say, based on my experience, those are a rare presentation in the sense of petechiae, jaundice, but those would be obviously other features that would trigger you to do blood work for other reasons. But those would be things I would think of as well. Sure.
Sounds perfectly reasonable. And that's interesting. I didn't know that kids generally don't get parasites, so we don't need to send for stool O&P. Generally speaking, I feel guilty now that I've wasted a lot of healthcare dollars on sending O&P in children with diarrhea that are high risk.
I'll clarify. I wouldn't say that kids generally don't get parasitic infections. They do. They typically do not present with bloody diarrhea in children, acute bloody diarrhea. They tend to have more chronic abdominal pain or chronic diarrhea, failure to thrive, or there's obviously a travel history if they're coming from an international country, they've recently immigrated to Canada, et cetera. But there is evidence that, we did a study in Alberta that less than 1% of children tested for O&P in an emergency department are actually positive on that testing. And the question even is whether some of those are true positives versus false positives. So it's a very small proportion. So my practice, generally speaking, if they are not an international traveler, is not to send O&P, even in children with bloody diarrhea.
Great, Pearl.
The other pearl I'll dive into there while we're talking is C. diff. which classically presents with bloody diarrhea. I do not recommend that as a regular frontline test in children without risk factors for C. difficile infection, even in the presence of bloody diarrhea. We do know the carriage rate, particularly in children under 2 years of age, can be as high as 40 to 50%. So particularly under 2 years of age, do not send it unless there is a high risk factor like they've been recently hospitalized on broad spectrum antibiotics. And then even in older children into the teenage years, there is carriage rates of approximately 5%. So I would generally start by testing for bacteria. And if whether they follow up in an emergency or with their family physician later on, if the bloody diarrhea is not due to a bacterial etiology and they're still having bloody diarrhea, that would be a very important second line test, for example, in a teenager.
Got it. Okay. So your stool PCR that you send off is going to be testing for Salmonella, Shigella, Campylobacter, and S-TEC. And that's what you want to send off for these kids with acute, stable bloody diarrhea. If it's more chronic, then we got to start thinking maybe about C. diff, especially in the older kids. And if they've been traveling, then yes, that's when you do want to send for ova and parasites. But generally, we shouldn't be sending for ova and parasites. Now, I want to understand a little bit more about S-TEC. Like, what exactly is S-TEC? It's Shiga toxin producing E. coli. What is it, and why is it so important for us to recognize?
Yeah, so I mean, the name kind of gives it away. In that there's obviously in clinical medicine and microbiology there's lots of E. coli. UTIs are caused by E. coli 80% of the time in children, but that is not Shiga toxin producing E. coli. Traveler's diarrhea, for example, is usually from E. coli, but not Shiga toxin producing E. coli. Children can get sepsis from E. coli and E. coli meningitis. That's almost never from Shiga toxin producing E. coli. So this is a unique, separate relative cousin in the E. coli family of many other E. coli. The name says it's unique because it actually has a gene that produces Shiga toxin. So the important thing about Shiga toxin producing E. coli is they have the gene for it. The gene, there can be two different types of toxins it can produce. So it can produce Shiga toxin 1 or Shiga toxin 2 or both. And so when it makes the toxin, it's the toxin that causes both the damage in the intestines, the intestinal epithelial lining that causes the abdominal pain, the bloody diarrhea, the mucousy stools. But the Shiga toxin translocates from the gut into the circulation, distributed across the body in almost every organ. But the catch is that it's more prominent and most prominent in the glomerulus of the kidneys. So the kidneys are, as we know, are a hugely vascular organ, right? It's this ball of capillaries put together. And so when the toxin goes into the kidneys and the kidneys filter all of our blood, this inflammation that we see, the shearing, and people have come up with different images to portray it, but basically it creates one of the nephrologists I work with says it's a chicken wire mesh. And so when your red blood cells are then going through this mess of debris, they get hemolyzed. And also, as you can imagine, this is happening in the kidneys, so it starts to cause blockage in the glomeruli. They no longer function very well. They're damaged, which causes the acute kidney injury. And then all of this vascular damage causes an inflammatory response and the aggregation of platelets that then compounds this inflammatory response, leading to further blockage, but also thrombocytopenia. And that's the triad of the hemolytic uremic syndrome that is the potential complication of S-TEC infection. Now, the catch is not everyone gets that. The reality is most children will have some degree of this process going on, but it all depends on the child as well as the toxin and the amount of toxin. So one of the most important things that we do in Alberta, we actually do very, very well, and I encourage people to work with your local laboratories, is to make sure you can identify the toxin type that the S-TEC produces, because that influences my decision-making immensely. We know that if it makes only Shiga toxin 1, the risk of developing the hemolytic uremic syndrome, which is the triad of anemia, thrombocytopenia, and acute kidney injury, is well below 1%. They're almost case reports. Whereas if you make Shiga toxin 2, the risk of developing HUS in children under 5 years of age is approximately 20%. Very, very high risk. And then the other piece that's really important to know is if they develop HUS, the risk of being on dialysis within a week is 50 to 60%. So if you kind of look at it, kids under 5, 20% risk of developing HUS and 50% risk of dialysis, that means 1 in 10 kids will be on dialysis in a week. That is a very, very high morbidity rate for an otherwise generally previously healthy child who came in with diarrhea one day. So that's kind of why I highlight that, and also the importance of identifying the toxin, because then that allows you to risk stratify your management. So if I know they make Shiga toxin 2, my management is much more proactive and aggressive, and we can talk about that. Whereas if they only make Shiga toxin 1, my recommendation to physicians is no special follow-up is required. Treat them as any other diarrhea. And we'll come back maybe to antibiotics, but do not treat with antibiotics. The bacteria should clear from the system and no complications should ensue. So that really is very, very different. There's also evidence that we've accumulated that in children who have diarrhea, if you don't have stool available in the ED to test, you can do a rectal swab actually, collect stool that way, and send that off to your lab. Now, I don't recommend that emergency physicians start doing this without discussing it with your lab and making sure your lab has agreed to process these specimens. When I get an S-TEC positive result in Alberta and almost everywhere else, you don't get the toxin type yet. So the first thing I want to know is, did the child have bloody diarrhea? And what was their duration of diarrhea already? And that is for 2 reasons. One, non-bloody S-TEC have a very low likelihood of making Shiga toxin 2, not a none, not a nil, and a very low likelihood of causing HUS. So in children with non-bloody diarrhea, pending toxin typing, I assume they are going to be a low-risk S-TEC, and I don't do anything further at that point in time until I get further information. Children with bloody diarrhea, on the other hand, I assume are going to be a high-risk S-TEC or an STX2 producing pathogen until proven otherwise. So that is my first step in my algorithm. The second question I ask is, how long have they had diarrhea? So if they've had diarrhea for more than 10 days, the risk of developing HUS at that point in time is very low. So if they had blood work done already at the index ED visit, and there was no signs of microangiopathy, and they're already more than 10 days, I don't do anything further with that child. I assume they're probably past the HUS window. On the other hand, if they're less than 10 days, I still assume they're at risk for HUS because HUS develops a median of 7 days after diarrhea onset. And so it doesn't mean it can't happen after 10 days, but it's very rare that it happens at that point in time. If they never had any blood work done and they do have bloody diarrhea, then I do recommend at least one set of blood work, even if they're after 10 days, to make sure there's no signs of microangiopathy.
Let me just clarify that. So the duration of bloody diarrhea is key because if the diarrhea is more than 10 days, then they're deemed low risk for HUS, which usually develops around day 7 or so. I want to talk definitely more about risk stratification, like which kids do we really need to worry about. Already we know that if you get a result that's toxin number 2, then you know that that's going to be high risk automatically. If they're more than 10 days, that's low risk. And that one key point is that whenever possible, get the stool in the ED because we do this quite often, sending them home with a bottle for CNS. Sometimes they don't get it done. It's delayed, and you're just delaying treating these kids who might be very sick. And that, if your lab has it, a rectal swab is a great way of getting that result that you need quickly if the child cannot produce a stool in the emergency department. So that's something that we should be speaking to our labs about for sure. I want to go on then about risk stratification. So how exactly do we risk stratify besides knowing that it's toxin 1 or toxin 2 and besides the duration of diarrhea? Really keep it simple of bloody diarrhea, duration of illness, and if I know the toxin result. Those will all tell me if any of those are positive and the toxin 2 is positive, then I know they are high risk, and then that initiates my management strategy for what do I do with high risk, which really is the next question. If they're not high risk, I then deem them low risk and I don't do anything further.
children who are high risk, what we have learned is that dehydration or intravascular volume depletion at the time of HUS development is associated with adverse outcomes. And by that, what we know is if you are dehydrated, you are more likely to require dialysis. You are more likely to die as well. So those are the two big things. And because we've made that association, and that's been consistent in the literature for 20 to 30 years, number one, what I want to do is make sure these children do not have intravascular volume depletion. So I bring them back to the emergency department or to a follow-up clinic. We assess their hydration status. We give IV fluids if they need to receive, if they're intravascular volume depleted. And the most important thing is, even if they look reasonably well, is to do blood work. So I do blood work every 24 hours until they reach what we call termination criteria. And that'll be your next question. I'll come to that one, Anton. But we do this blood work because what we're looking for now is trends of development of microangiopathy, because HUS doesn't develop de novo. It doesn't suddenly go from totally normal to HUS over 5 hours, although it does develop quickly. But what we also know is kids who are identified as having HUS before it develops and is fulminant do better. So they don't tend to present with a hypertensive crisis and seizures. They don't tend to present with severe hyponatremia with a sodium of 115. They don't tend to present with a creatinine of 500 and have to go to the OR that moment for dialysis. So when we can identify evolving microangiopathy, we can actually start managing them, making sure we're addressing the symptoms and potentially preventing the adverse outcomes. So what we do know, and the number one thing that we see first almost always in every kid who's developing HUS is the platelets drop. And so the reason it's helpful to have early on blood work is to know what is their normal, what is their pre-microangiopathy platelet level. So often these kids will come in, you do blood work on day 5 of illness, which may be day 1 or 2 of bloody diarrhea, and they have a platelet count of 400, let's say. That's great. The next day, if you do blood work on them and you call them back because you know they have S-TEC, their platelet count comes back at 275. And had you not known that it was 400 the day before, you would say 275. That's great. But now it's gone from 400 to 275, and you're like, okay, are there signs of microangiopathy? What I tend to do on all these kids is an LDH, which can be an early marker of red blood cell hemolysis. If there isn't, and their platelet count is still 275, I'm not too worried if everything else is good, but I'm going to check it again the next day. And what we do see on the kids who develop HUS is that platelet count will go from 275 to about 50 the next day. It's a dramatic drop, but their BUN, creatinine, and hemoglobin will all generally still be stable. So this is a kid that I would then admit to hospital because I know they've got microangiopathy. I know they're developing HUS. I know their hemoglobin is going to drop, and I know their creatinine is going to rise. And I know they're going to be at risk for electrolyte abnormalities. And I also know that dehydration in this group is going to put them at higher risk of adverse outcomes. So those are all kind of the management strategies that aren't so much ED-based, but really hospital-based. And that's kind of what our pediatricians here are very attuned to. And so we do admit them, we hospitalize them, and we use, we could talk about hydration strategies because that's kind of a big area of focus right now. But that is what I'm looking for with high-risk kids is daily blood work every 24 hours and monitoring that platelet count and the other parameters. But it's the platelets. As soon as I see those drop, I know where we're headed. I've seen this story before, and it's going to happen again to that type of child. And so you really want to be attuned to it, and don't just assume because a platelet count is normal, that it's normal for that child, which is why kind of important that we monitor these trends over time.
All right. So just to review there, in terms of high risk factors, we talked about, first of all, if they have bloody diarrhea as opposed to non-bloody, if it's toxin 2, not toxin 1, the duration of diarrhea. So if it's more than 10 days, it's low risk. Less than 10 days, we should just assume high risk. And that dehydration is a major high risk factor. And so that's something that's important for us to address in the emergency department to get those kids' volume repleted as soon as possible. And then lastly, thrombocytopenia, which will be your first marker that it's heading towards HUS and badness. Got it. All right. So much to take in there. So much that I learned. Thank you so much. If there were 3 key take-home points about bloody diarrhea, S-TEC, HUS that you'd want to drive home for our EM Cases audience, what would those 3 points be?
Yeah. So, number one is, importance of diagnosis. S-TEC represents a small proportion of all children with bloody diarrhea, but is perhaps the most important cause of bloody diarrhea in children. So diagnosis is required quickly, efficiently, and knowledge of how your laboratory handles stool specimens and what data they report. So obtain a stool specimen as soon as possible. The second is children with S-TEC, even if they clinically seem to be doing better, are at high risk for development of complications. This is a really important disease, and most people do not see enough S-TEC infections to really understand the morbidity associated with the illness, because like most things in children, most children get better. So be aware that it is a disease with potential for severe morbidity and even mortality. And then number 3 is close monitoring of these children and attention to hydration status is vital. And if you're not used to, or your institution, if you're in a peripheral community, because a lot of these cases happen in rural communities, then really reach out to individuals with expertise in the management. And that is really vitally important to initiate monitoring early, maintain hydration status early, and ideally have them in the right location to manage complications should they occur.
Fantastic. Thanks so much, Dr. Friedman. I hope we can have you back on EM Cases. And I'm assuming that you will be at ISEM in Montreal in May. Looking forward to hopefully hanging out and chatting a bit more at ISEM, and looking forward to the conference. It should be a great one.
Yeah, my pleasure. Thanks for the excellent questions and really reflections on an important entity and disease for children. So, thanks, Anton.
All right, next up, as part of our Best of the University of Toronto EM series, we have the brilliant Justin Morgenstern. Now, we know that the earlier we give epinephrine in cardiac arrest, the better the chances of survival. So in an out-of-hospital cardiac arrest, where the patient usually doesn't have an IV secured, why not give IM epinephrine? Now, you might have heard about a recent study on this topic that's been debated widely. At EM Cases, we like to let the dust settle after the debates and give you a balanced approach to these important questions. Take it away, Dr. Morgenstern. And now for the best of University of Toronto emergency medicine.
A cardiac arrest study with a mortality benefit? Not just that, but also with improved neurologic outcomes? That's just unbelievable. But wait, should we believe the hype? So the paper we're going to talk about was published in Resuscitation in August 2024. It was by Palantinis and colleagues. And the Twitter summary of this paper seems to be that a large IM dose of epinephrine saves lives. But let's look a little closer at the details. First of all, this is not a randomized trial. It was a before and after trial that takes place over a very long period of time. In the before group, patients received standard ACLS. In the after group, as soon as epinephrine was indicated by ACLS, they gave a 5 milligram dose of epinephrine IM while working on vascular access, and then after that they just did normal ACLS. The idea was to get the epinephrine in quicker, and it definitely seemed to work. The epi was given about 3 minutes faster in the after group. Now, over about 14 years, they enrolled 1,405 patients. And on paper, the results look really good. You can see why the Twitter mobs were excited. Their primary outcome was survival to hospital discharge, and there was a statistically significant 4% absolute decrease in mortality. It was 7% versus 11%. That is incredible. And even more important, there was also a statistically significant improvement in good functional outcomes, 6 versus 10%. Now, those numbers sound a little bit weird to me. It says that basically everybody who survived also had great neurologic outcomes, which just doesn't jive with other cardiac research. But at least at face value, those are amazing results. However, this was not a randomized trial. This is a before and after trial, and that leads to all sorts of problems. It's unblinded, and the Hawthorne effect is always possible there. But maybe the biggest issue is that this trial takes place over 14 years, and over 14 years, many aspects of care might change over time. And so we might expect to be seeing the effect of some other change, not just the IM epinephrine. And there were probably lots of changes, right? The before group was almost certainly receiving quote unquote therapeutic hypothermia. The after group definitely should not have been. And they don't tell us about advanced therapies, things like ECMO that have come into play over the last 14 years. They don't tell us if airway management changed over time, but we know that supraglottic airways result in better outcomes than intubation attempts. So a million things might have changed over the 14-year time that this trial was run. And in fact, they demonstrate some of those changes in the baseline data that they show us. Bystander CPR, maybe the most important link in the chain of survival, was way higher in the after group. It was 14% higher. I'm pretty sure a 14% increase in bystander CPR could easily explain a 4% increase in survival, no? And it wasn't just that. The after group was also on average 3 years younger. So you have younger patients getting more bystander CPR. Are you surprised at all that the outcomes are better? Maybe this has nothing to do with the IM epinephrine. And that brings us to maybe the most important step when you're doing a critical appraisal of observational data. You have to fit it in with the available scientific literature. For epinephrine, we have a couple of big RCTs in cardiac arrest. And the results are somewhat questionable. Epinephrine does seem to have a small improvement in overall survival, maybe 2%, but it definitely does not seem to improve neurologic outcomes. Observational data just can't overrule RCT data like that. So I think you have to think about how to best fit all of that together. So considering that the best available data, the RCT data, says that epinephrine does not improve neurologic outcomes, I think it's a very safe bet to say that the results we're seeing in this study are almost certainly the result of confounding and not the results of epinephrine. That the improved outcomes are probably because these are younger patients getting more bystander CPR or some other confounder that we can't see. This is good hypothesis generating data. This definitely warrants a follow-up RCT, but this really should not guide current clinical practice. Now, that being said, if you really think that epinephrine is a good idea in cardiac arrest, then sure, it makes sense to give it as early as possible, and the IM route can help you do that. Look, I don't wait for vascular access when I'm treating status epilepticus. I just give IM benzos. And so it makes sense to say the same thing in cardiac arrest. The flip side of that is, early in a cardiac arrest, you might have a lot better things to do than drawing up multiple vials of epinephrine to get a big enough IM dose. Personally, I do not think that there's convincing data that epinephrine is a valuable part of ACLS at all. So I would not be changing EMS protocols based on this data. I think you wait for the RCT.
Thanks so much, Dr. Morgenstern. We were very lucky to have Dr. Morgenstern speaking at the last EM Cases Summit just a few months ago, where he gave an excellent talk amongst the 25 or so other world-class speakers. If you missed it, no problem. We're offering video streaming packages of the recent summit through emcasessummit.com. And we're also offering 50% discounts off past EM Cases Summit video streaming packages. It's all fully CME accredited. This offer is for a limited time only. Your last day to get your video packages will be May 23rd, just a few weeks away. The packages also include ebooks edited by me, summarizing all the talks. It's an easy way to get high-yield CME credits on your own time. You'll find all of it at emcasessummit.com. All right, moving on. Did any EM casers out there see a patient with a fever this past winter? Where I work, we were slammed with febrile patients, the vast majority of whom had viral illnesses and could be sent home, even if they were a returning traveler. Dr. Matthew MacArthur is up next. He's going to give us a refresher on a particular bug that's quite common, like really common in the returning traveler, and that we need to consider in all these patients. Take it away, Dr. MacArthur.
You're seeing an otherwise healthy 38-year-old male who walked into your emergency department with a chief complaint of fevers and feeling generally unwell. He has a temperature at triage of 39.3 degrees Celsius, and the remainder of his vitals are within normal limits. He reports that over the last 2 days, he has been experiencing fevers and chills, joint pains, and headache. He denies shortness of breath, chest pain, vomiting, diarrhea, abdominal pain, or genitourinary symptoms. He is not toxic appearing, chest and abdomen exam are benign, oropharynx and mucous membranes are normal, there's no neck stiffness or meningitic signs, and he has a faint macular rash on his torso, back, and extremities. Blood work obtained at triage showed mild thrombocytopenia of 110 and white blood cell count of 3.9, with the remainder of the CBC and basic chemistries normal. Liver enzymes are modestly elevated. This patient's presentation is very nonspecific and could be caused by a huge number of infectious or even non-infectious causes. But is there anything important you forgot to ask about on history? You ask the patient about any recent travel. He tells you 3 days ago he got back from a 1-week vacation in Thailand with a group of his friends. He denies any high-risk sexual behavior or needle exposures. So now we have a case of fever in the returning traveler, and given the timeline of the patient's symptoms, we have to think about endemic infections that the patient could have picked up in Thailand at the top of our differential. So what tests would you order for this patient? And what is your disposition? Do they need admission, or can they be discharged from the ED? For this episode, I'm going to tell you everything you need to know about dengue, one of the common causes of fever in the returning traveler, and then we will go back to the case to wrap things up. Dengue is a viral infection in the flavivirus family, a family which also includes West Nile, yellow fever, and Zika. Dengue is transmitted between humans by mosquitoes in the Aedes genus. Dengue is endemic in more than 125 countries in tropical and subtropical regions, and about 4 billion of the world's 8 billion people live in dengue endemic areas. There are an estimated 400 or so million dengue infections per year, making it one of the most common causes of febrile illness in dengue endemic regions. Dengue has been an increasing public health concern lately due to larger outbreaks occurring over the last decade, likely in the wake of climate change, increasing population, and urbanization. There are 4 dengue virus types, all of which cause acute infection in humans. Dengue is not known to cause chronic infection, unlike some other viruses we see in our practice, like herpes, hepatitis C, and HIV. When you think about it, almost all of the infections we deal with on a day-to-day basis can cause varying severity of illness, from the mild and self-limited to the critical and life-threatening. Dengue is certainly no exception. In fact, about 75% of dengue infections are completely asymptomatic. However, we should still take dengue seriously because 2 to 5% of infections can progress to severe dengue, which is life-threatening. Symptomatic dengue infection tends to progress through 3 phases: the febrile phase, the critical phase, which is only present in severe cases, and the recovery phase. Symptoms of dengue typically start between 4 to 7 days after the bite of an infected mosquito. The febrile phase of illness usually lasts between 2 to 7 days, and it involves the rapid onset of high fevers with nonspecific symptoms including headache, joint pain, eye pain, myalgias, nausea, vomiting, and macular or maculopapular rash. Some patients will develop hemorrhagic changes such as minor bleeding and petechiae. You can perform the tourniquet test, in which a blood pressure cuff is inflated to halfway between the systolic and diastolic blood pressure for 5 minutes. And if more than 10 new petechiae appear in a 1 square inch of skin within 1 to 2 minutes of deflating the cuff, the test is positive and suggestive of dengue. Blood work may reveal a leukopenia and thrombocytopenia, as well as modestly elevated liver enzymes. Confirmatory lab testing for dengue is blood work, which is sent for viral molecular testing as well as IgM levels, both of which should be positive within 4 to 7 days of infection. Around the time of defervescence, as the fevers get better, usually about 3 to 7 days into the illness, a small subset of patients will enter into the critical phase and progress to severe dengue. The hallmark of severe dengue is plasma leakage, in which the plasma literally leaks out of the blood vessels into surrounding tissues. Consequences of this phase include shock due to depleted intravascular volume, bleeding, and organ dysfunction. The main treatment is fluid resuscitation with IV crystalloid according to published protocols, and supportive care. Patients at increased risk of progressing to severe dengue are the very young and very old, those who are immunosuppressed or have baseline comorbidities, and those who have had a previous dengue infection. Remember, there are 4 different dengue viruses, so infection with a second dengue virus after a previous infection has a higher risk of progressing to the severe phase compared to a first-time infection. The final phase of dengue infection is the recovery phase, in which plasma leakage and hemorrhage resolve, vital signs stabilize, and extravasated fluids are reabsorbed over the span of a few days. An additional rash may develop during the recovery phase, and some adults may develop severe post-viral fatigue lasting days to weeks. Historically, dengue was classified into 3 subtypes: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. However, the updated World Health Organization classification system from 2009 provides a more streamlined approach to evaluation and management. In this system, dengue illness is classified as either dengue, dengue with warning signs, or severe dengue. There's a fantastic and succinct pocket guide produced by the United States Center for Disease Control, which goes over the diagnosis and management of dengue, and I will include it in the show notes. Patients living in or coming from an endemic area who have fever plus any 2 of aches and pains, rash, nausea, vomiting, leukopenia, and positive tourniquet test get a presumptive diagnosis of dengue. Warning signs for progression to severe dengue include intense continuous abdominal pain or pain on palpation of the abdomen, persistent vomiting, fluid accumulation such as ascites or pleural effusion on POCUS, mucosal bleeding, altered mental status, hepatomegaly, and progressive increase in hematocrit in consecutive measures 6 hours apart. Finally, severe dengue consists of dengue patients with any of shock, clinically significant bleeding, or severe organ impairment. Treatment for dengue is entirely based around supportive care, without any specific therapies or vaccines for dengue. For otherwise healthy patients with dengue without warning signs, they can be managed as outpatients, with advice to maintain good oral hydration, close outpatient follow-up, and to return to hospital if they develop any warning signs. Tylenol is recommended for fever control. Consensus guidelines recommend against the use of NSAIDs and corticosteroids due to concern of increased risk of GI bleed. However, there's not great evidence to back up this recommendation. For patients with dengue who have risk factors like diabetes, kidney disease, and heart disease, or age less than 1 or greater than 65, hospital admission for close observation is recommended. Patients with dengue plus any of the warning signs I mentioned earlier should be admitted and started with crystalloid fluid resuscitation, which starts at 10 milliliters per kilogram over 1 hour, followed by reassessment and gradual tapering of IV fluids. Make sure you're using isotonic fluids here, as hypotonic fluids like half normal saline will make the extravasation worse. Patients with severe dengue get even larger volumes of initial fluid resuscitation with considerations for IV colloids if not responding to aggressive crystalloids, as well as other aspects of ICU-level care. Many of these patients will have a thrombocytopenia. However, prophylactic platelet transfusion is not recommended as there's no evidence of benefit and there may be harms associated with platelet transfusions. So now we know what dengue is and the approach to evaluation and management, let's get back to our case. We have an otherwise healthy, young patient who returned from a week-long vacation in Thailand 3 days ago and has 2 days of fevers, joint pain, and headache, and a new skin rash. Vitals and physical exam are unremarkable, and he has a mild leukopenia, thrombocytopenia, and transaminitis. For this patient, the differential includes major causes of fever in the returning traveler, like dengue, chikungunya, Zika, leptospirosis, and malaria, though the timeline and symptomatology seem to fit dengue the best. I would send off blood work for all of these infections. But before I do that, I would definitely call my local infectious disease doctor and tell them the story after my initial history and exam to see if there are any other tests they would recommend and ask for advice around disposition and management. This patient has fevers, headache, and rash, but no neck stiffness, no meningitic signs, is not septic or toxic appearing, and has no seizures or neurologic symptoms. I would absolutely offer the patient an LP to rule out meningitis, but I think a shared decision-making approach around deferring LP until the patient becomes more symptomatic is not unreasonable, as there aren't any hard signs of meningitis, so our pretest probability is low. The procedure can be uncomfortable and anxiety-provoking, and it does carry a small risk of complications, including unsuccessful LP attempt, post-dural puncture headache, bleeding, and infection. Now that we've sent off all these tests, what is our disposition for this patient? We can make a presumptive diagnosis of dengue based on the patient's symptoms. The patient does not have any warning signs or risk factors for severe dengue, so it is appropriate to manage them in the outpatient setting with close outpatient follow-up. You should recommend the patient take Tylenol for their fevers, but avoid NSAIDs, and recommend they push oral hydration at home with lots of fluids, salty snacks, and foods. You should advise them to come back to the hospital if they develop any warning signs such as abdominal pain or persistent vomiting or altered LOA or melena stools or developing chest pain and shortness of breath. So you send the patient home with good discharge instructions and outpatient follow-up. A few days later, their IgM serology and viral molecular tests come back confirming a diagnosis of dengue. The patient does well with outpatient management, their fevers stop around day 5 of illness, and within a week they're back to feeling normal. So that's all for this episode. Thank you so much for listening, and I hope this helps next time you're dealing with fever in a returning traveler.
Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. It's always an absolute pleasure to introduce our go-to traumatologist and EM doc, Andrew Petrosoniak. Now, we've dedicated an entire episode in the past to trauma in the older patient on EM cases, but here Petro is going to talk specifically about some high-level imaging decision-making.
I think every one of us has seen a geriatric patient with low-energy trauma. Many of us have seen them with unexpected injuries from seemingly minor trauma, and the sequelae of these injuries are not always related to their perceived severity. Think ground-level fall or low-speed MVC. The vast majority of these patients do not present with any hemodynamic instability. For those that do, I think we all know how to manage the sick trauma patient. We're not going to talk about those today. But here's a case to help guide our discussion. An 80-year-old male presents to the ED. He fell one step while leaving his house. He hits his head, but no LOC. He has hypertension, diabetes, and compliant with appropriate medications. He also takes aspirin, but no other anticoagulants or antiplatelets. He has a mild headache with a laceration that requires repair. He has mild left-sided chest pain where he landed. His vitals are normal and there's no neurodeficits. So what do? Do we image? Do we do nothing? In this patient population, it requires a shift among us as clinicians because an injury in an 80-year-old could result in significant clinical course, while the same injury in a 30-year-old might be just fine. For example, rib fractures. These are injuries that we often think are of minor. There's no treatments often, but the risk of death from rib injuries is 2 to 5 times higher in those older than 65 compared to those younger than 65 years of age. And as the number of rib fractures increases, so does mortality. In fact, it could be as high as 11% in those with 6 rib fractures and 34% in those with 8 or more rib fractures. So now that I've put the fear of God in everyone, that all these geriatric patients could have substantial morbidity, mortality, how should we proceed? Honestly, it can be very difficult, very challenging to decide what to image. But let's start at the head and move down to the abdomen and pelvis, looking at how we can decide on imaging for each of these body areas. We do have very good studies from the Ottawa group using the Canadian CT head rules and the C-spine rules, which supports imaging among patients greater than 65 when they meet inclusion criteria. It's worth mentioning that these studies often only guide us within specific patient populations, though. There are clear inclusion criteria that are often forgotten, and I want to flag those. The CT head rules are only supposed to be applicable for patients who are GCS 13 to 15, which I think we all know. But importantly, they had to have had an LOC, witness disorientation, or definite amnesia. So this study doesn't provide guidance on whether to image if the patient hits their head but has no LOC or witness disorientation. Not an uncommon event in these situations. Similarly, the C-spine rules also have inclusion criteria, meaning you can only apply it, or it's only intended to be applied, for patients with traumatic neck pain, or if they have no neck pain, but they do have visible injury above the clavicles, they're non-ambulatory after the injury, and they sustained a dangerous mechanism. So with that in mind, I do use these criteria frequently. The quintessential patient excluded from these rules is the one who falls from standing or down a single stair, hits their head, but is awake and oriented the entire time. Often has no neck pain, but a lack on the head. So what do we do there? Just like the patient in our case. We're all worried about not scanning that patient and them ending up having a subdural or a C2 fracture. Or what if they're on antiplatelets or DOACs? So we're left with clinical judgment. In the event the patient doesn't fit nicely into the study criteria, I still have a pretty low threshold among those aged 65 or older to image. I can't really provide you with exactly what I do every time because there's probably some variability even in my own practice. But it's likely if they hit their head reasonably hard or they seem quite frail, I'll err towards a CT head. And often I'll add a C-spine CT should I proceed with the CT head anyways. There is some recent data, a study in CGEM by McCallum et al., that indicated among patients 65 years presenting with low-level falls, the main predictors of C-spine injury were head injury, neck pain, and increasing age. In fact, there's a 40% increase for every 5 years of increase in age, leaving the authors to conclude that if patients do not have head injury or neck pain, then it's very unlikely that they have a C-spine injury, and imaging should not be ordered. I think if the patient seems very reliable, has absolutely no neck pain, no motor deficits or paresthesias with a full range of motion, then I often won't image, or at least I'll have a conversation about the decision and make a shared decision with them. So now let's move on to when we should image the chest and abdomen. To provide some perspective specifically related to chest trauma, 16% of patients age 65 or older and 28% of those 85 or older who have blunt chest trauma develop a complication, most commonly pneumonia or respiratory failure. We really have no guidance here in the literature. To make matters worse, the chest x-ray only demonstrates rib fractures in about 50% of the time. And in one study among elderly who had a fall from standing, none of those with pulmonary contusions were identified on chest x-ray. I think we can all recall seeing a patient with a normal chest x-ray, but for some reason they undergo a CT chest, and there are multiple rib fractures or pulmonary injury that really warrants admission. The real question is whether admitting these patients who have radiographically occult injuries, i.e. normal chest x-ray, but then findings on CT, results in better outcomes. The data is conflicting, with one study of geriatric patients who had ground level falls not having any difference in outcome, while another showed 13% of those requiring a major intervention, such as a chest tube or intubation, who had normal chest x-rays, despite ultimately having a significant finding on the CT chest. Recently, the East Trauma Group of trauma surgeons, they did a prospective study to develop a decision algorithm, not probably ready for prime time yet, as there's been no external validation, but I do think if you're looking for guidance, then it can provide some help. And what they did was they looked at this in terms of imaging for the CT head and C-spine, as well as providing some guidance around the chest abdo-pelvis. Recognizing this is American, they certainly did err towards more imaging than less. Among the broader geriatric population, they pretty much advise CT head and C-spine for all. I think they've probably extended this a bit too general. For example, a minor MVC who doesn't hit their head doesn't necessarily need a CT head. So clinical judgment is key. But should there be generalized blunt trauma, liberal use of the CT head and C-spine is reasonable. Then they advise CT chest abdo-pelvis if there's any of the following: abnormal torso findings or any high risk factors such as low GCS, which they actually say is less than 15, rapid deceleration mechanism, antiplatelets or anticoagulant use, intoxication, a distracting injury, or any emergency procedure. A couple of issues with this that I'll outline. They don't specify if aspirin constitutes antiplatelet use. This seems different to me than, someone being on dual antiplatelet or a DOAC, but that's more just my opinion. In addition, emergency procedures was quite a heterogeneous group spanning central lines to TXA. I understand the central lines piece, but TXA may not really have any relevance here. I will say that if you're doing a CT chest, it's probably worth to do the CT abdomen as well. Sometimes those lower rib fractures actually result in hepatic or splenic injuries. Also, any spine fracture warrants full spine imaging because there's about a 15% chance of another fracture somewhere else in the spine in patients with an isolated observed spine injury. So let's apply this to our case. It's the 80-year-old male, fell one step while leaving his house, hit his head, no LOC. He has hypertension, diabetes, and he's compliant with the appropriate meds. Remember, he takes aspirin, no other anticoagulants. He has some mild left-sided chest pain and a lac on his head. So where does that leave us? Well, we're back to good old-fashioned clinical impression and suspicion for injury. Obviously, start with a good history and physical exam. If they meet inclusion for the CT head and C-spine rules, then I use them. But if they don't, I make a judgment call, often erring towards imaging, especially as the patient's age increases. And if I'm not, I'm going to be very clear with my documentation about shared decision-making. The physical exam is important, but it's also important to recognize that geriatric patients may not have the same clinical findings as those younger. For generalized non-focal trauma, I'll often get the chest x-ray and pelvis x-ray. In addition, I do a FAST exam and an EFAST, making particular note of any pleural effusions, which might indicate that there is evidence of a hemothorax. If I decide not to image, or perhaps as I'm making the disposition decision post-imaging, I'll ensure there's a walk test I observe myself, and I find this incredibly helpful. My imaging thresholds will decrease in low-energy trauma as their age increase, or if there's anticoagulants, significant other injuries, or any episode of hypotension. Also, if I see rib fractures on a chest x-ray, I default to CT imaging. This differs from my practice in low-energy patients who are much younger. And if I decide based on my physical exam to image the chest or abdomen, I treat it as a thoracoabdominal injury and I just image both together. Now, for some of you, this may sound overly conservative, and I think it's okay in the absence of concrete evidence to create your own practice. But what really worries me is the presence of rib fractures and then the subsequent deterioration that I've seen so many times. So in this case, I'd image the head and C-spine. I'll do a chest and pelvis x-ray along with a EFAST exam. If the pain is significant in the chest, despite the normal chest x-ray after non-opiate analgesia, then I will proceed to a CT chest in this patient. But if they're doing well, then I'll do a walk test and see how it goes. So that's it. Have a low threshold for CT head and C-spine, even if they fall outside the criteria traditionally used for the decision rules. And then be diligent, especially with regards to rib injuries, and have a low threshold for CT when those who have significant pain on exam or documented rib injuries on chest x-ray.
And now a word from one of our sponsors, Easy Recess, the resuscitation assistant. Did you know that Easy Recess is brought to you by a nonprofit organization dedicated to improving care in resuscitation? This means that every dollar from your subscription goes to improving Easy Recess. But not only that, thanks to your contributions, Easy Recess can be made affordable for healthcare workers in developing countries so that they can also deliver the best care possible to their patients. If you want to help them in their mission, download Easy Recess and use promo code EMCases to get your first 2 months free, or visit easyrecess.com/EMCases for more details. That was some great food for thought for us to reflect on our own imaging practices from Dr. Petra Stoniak. Thanks so much, Petro. Last but not least, we've got Britt Long and Mike Gottlieb, and they're going to review for us TTP. Now, can you whip off the pentad right now?
Thrombotic thrombocytopenic purpura, or TTP, is a rare but important disorder that we have to recognize in the ED. While the incidence is around 2 to 4 cases per million adults, mortality can be really high, approaching 90% before current therapies. Thankfully, mortality rates are now down to around 4 to 30%, with early recognition in therapy. The really tricky aspect of TTP is that what we're classically taught doesn't always fit how these patients present, and in many cases, it's not even on our radar. In this Quick Hits episode, Mike Gottlieb and I are going to look at some of the key aspects of TTP.
So first, let's talk a bit about the pathophysiology. The central component of TTP is this enzyme called ADAMTS13. And ADAMTS13 is responsible for cleaving large von Willebrand factor pieces into smaller ones. Now in TTP, something prevents this ADAMTS13 from doing its job. And typically that's either a dysfunctional ADAMTS13 enzyme or autoantibodies against the ADAMTS13. And when this happens, the large von Willebrand factor multimers, they aren't broken down and they circulate as these large molecules where they start to accumulate platelets. This leads to clots and uses up the platelets, causing the patient to become thrombocytopenic, hence the name thrombocytopenic purpura.
As Mike mentioned, there are currently two forms, acquired and hereditary. While the acquired form is more common in adults and the hereditary form is more common in pediatric patients, you need to look for an underlying trigger. Autoimmune disorders, immunocompromised states, cancer, cirrhosis, medications, pancreatitis, pregnancy, and even sepsis have all been documented as underlying triggers. So with all of that, what should you be looking for on your history and exam in the ED?
In medical school, I remember memorizing this classic pentat of purpura, microangiopathic hemolytic anemia, fever, neurologic abnormalities, and acute renal injury. However, this is seen in less than 7% of patients with TTP, and many of these findings can be transient, so they may not even be present at the same time. So it's important we ask about current and recent symptoms. Petechiae and purpura, they're present in about half of cases, though active bleeding is rare. 40% of patients will have major neurologic symptoms like coma, seizure, or stroke, while roughly a quarter of patients will have more minor symptoms like headache or transient confusion. And up to a third of patients may have no neurologic symptoms at all. Interestingly, fever is only seen in about 10% of cases.
With the various ways TTP can present, lab tests can really provide us with some important clues. In the ED, you need to look for evidence of end organ dysfunction as well as hemolytic anemia. HIV testing can also be helpful because this can be an underlying etiology. The key is to think TTP in a patient with a hemoglobin of less than 10 grams per deciliter and a platelet count less than 150. An ADAMTS13 activity level less than 10% and the presence of an inhibitor are very specific for TTP, but these lab tests just typically aren't available in the ED setting. Blood smear can reveal schistocytes due to RBC breakdown, and you may also find an increased indirect bilirubin and lactate dehydrogenase, a decreased haptoglobin, and also reticulocytosis. A creatinine over 2 milligrams per deciliter and an abnormal fibrinogen or coagulation panel are not common in TTP and suggest something else like hemolytic uremic syndrome or DIC.
Several tools have been proposed to help with this diagnosis, and one of the most useful tools is the plasmic score. This was first described in 2017 and it uses a combination of history and lab findings like platelet count, hemolysis, active cancer, solid organ or stem cell transplant, a low MCV, the INR, and creatinine. Fortunately, these are all commonly available labs that we're already ordering, and this has been found to be 99% sensitive and 57% specific when the score is greater than or equal to 5.
Once you've diagnosed TTP, now what? Well, the primary components of treatment include addressing the underlying etiology and end organ dysfunction. Second, consultation with the hematology specialist. And third, focused treatment of the TTP.
Early treatments used to involve giving fresh frozen plasma to replace the non-functioning ADAMTS13. But this only had moderate success because those autoantibodies, they would just start attacking the new ADAMTS13. Modern therapy revolves more around plasma exchange and corticosteroids, and this has been found to substantially reduce mortality compared with FFP alone. How this works is plasma exchange removes the autoantibodies and replaces the non-functioning ADAMTS13 with a functional ADAMTS13 using donor plasma. That said, if it's going to take a long time to get the plasma exchange arranged, I think it'd be reasonable to start some FFP in the interim. Steroids, on the other hand, reduce the production of ADAMTS13 autoantibodies, and they should be started right along with a plasma exchange. Current guidelines recommend methylprednisolone 1 milligram per kilogram per day, but this can be increased up to 10 milligrams in patients who are refractory or worsening.
Other therapies include things like rituximab and caplacizumab. Guidelines now recommend rituximab as a component of initial therapy based on observational studies. But keep in mind, there are few RCTs evaluating rituximab with plasma exchange therapy.
While these patients are anemic and thrombocytopenic, active bleeding is rare, and transfusions for the most part aren't necessary. Platelet transfusions used to be thought to feed into this fire and lead to worse outcomes, but the most recent evidence suggests it doesn't really have an impact. If the patient has severe thrombocytopenia and major bleeding, or they're going to have some invasive procedure, then it's reasonable to give some platelets, but we don't need to give these routinely. Thromboembolic prophylaxis is also important, as roughly 14% of patients will experience a venous thromboembolism. And you're going to use regular or low molecular weight heparins along with aspirin in those patients with a platelet count over 50. If the platelet count is less than 50, we're pretty much just going to use graded compression stockings. Hopefully this clears up a tricky diagnosis. Thanks for listening.
Well, that about wraps it up for this month's EM Quick Hits podcast. Thank you so much for listening. Thanks so much to the guest experts for their insights. Hope you all learned a few things about TTP, trauma imaging in the older patient, dengue fever, IM, epinephrine in cardiac arrest, and pediatric diarrhea. Until next time, take it easy.